Number one, in a sensitized patient, the most precise method to evaluate a pregnancy affected by alloimmunization this is answer A, middle cerebral artery Dopplers. The other tests listed here would be tests that may be in the initial workup or finding problems or concerns related to the pregnancy or monitoring other things. However, once the patient is sensitized, the most precise method, looking at the pregnancy and what's going on with it, is middle cerebral artery Dopplers. Number two, which of the following is an example of a direct maternal death? The answer here is B, uterine rupture exsanguination. Now, some of the other answers here will help us to understand the definitions of what these things mean. Now, A is an indirect maternal death. So again, I'm going to put indirect for answer A. We described answer B as a direct maternal death. Answer C is a non-maternal death. And answer D is an indirect again. So let's understand these definitions. Answer A, aortic stenosis complicated by pregnancy, indirect maternal death. The aortic stenosis was present before the pregnancy started. It's not a cause or a problem from the pregnancy. It's there before the pregnancy started. The pregnancy exacerbated possibly problems with it, and it caused the death of the pregnant patient, which therefore makes it an indirect cause of maternal death. Compared to uterine rupture exsanguination, which is completely a pathology, physiology, and relationship with the pregnant state itself. Therefore, being produced by the pregnancy and being caused by the pregnancy makes it a direct maternal death. Answer C, motor vehicle accident death, has nothing to do with a pathology that was present before the pregnancy began or a pathology that developed during the pregnancy. This person was in a motor vehicle accident, unfortunately met their demise, and they happened to also be pregnant. Therefore, this is a non-maternal death. Answer D again is a maternal death as a result of mitral valve stenosis. The mitral valve stenosis was present and it was a pathology outside of the pregnancy. The pregnancy may have exacerbated and made it worse, but again, it was there before and it caused a death. Therefore, it's an indirect maternal death. Number three, while attempting to deliver the fetal head in a breech presentation at 28 weeks, you note head entrapment by the cervix. What is the next best step? This is going to be answer D, a Drouchin's incision. If you don't remember the Drouchin's incision, it's your upside down Mercedes symbol. The Drouchin's incision is a physical cutting of the cervix at those areas to allow it to open up and allow for the entrapped head to pass through. Now remember, preterm deliveries are often asking you questions about head entrapment because before 32 weeks is going to be a breech question because the head to abdomen before 32 weeks, the head is huge. So if you're looking at the ratio of the head to the abdomen before 32 weeks, the head is huge compared to the abdomen. Once we hit 32 weeks, the head and abdomen ratio are pretty 1-to-1. After 32 weeks, you should know that your abdomen gets bigger and your head stays less than the abdomen circumference. So therefore, always look for those preterms before 32 weeks to be doing something about breech delivery and what your decision is going to be regarding that. Now remember, there are other options here, such as terbutaline and prog maneuvers and also things like general anesthesia. However, the safest out of these choices, the things with the least morbidity and mortality, the thing you can do the quickest and have a result that you know will take effect, such as cutting the cervix away, is the Drouchin incision. When choosing answers for an examination, you should always make sure it's something that you can do directly, it's the cheapest cost, causes the least morbidity and mortality, and is the option that beats the other options out because you have the most physical control over it. Therefore, you're not guessing if it's going to work or not. 4. The ultrasound finding consistent with stage 3 twin-to-twin transfusion syndrome is answer A, absent or reverse end diastolic flow. If you remember, there's 5 stages of the Quintero staging for twin-twin transfusion syndrome. Let's go ahead and take a look at those 5 stages and see if we can find an easy way to remember them if you don't have them down. Stage 1, I like to call Ollie-Poly. That's where you're going to have your discordant amniotic fluid volumes, but there's still urine. So I don't even think about it at that point. I just think about the Ollie-Poly being present. Stage 2, I put P no more. This is going to be meeting the criteria of stage 1, which is that Ollie-Poly, but urine is not visible within the donor bladder. So P no more. Stage 3 is meeting the criteria of all stages above, and this is when your abnormal Doppler studies of the umbilical artery, ductus venosus, or umbilical vein go bad. So this is Dopplers go bad. Stage 4, of course, again, meeting other things above it, but can be frankly diagnosed with the presence of Frank hydrops or ascites. So I go ahead and I just put hydrops and ascites for stage 4. Now, the important thing to know about stage 4 is that can be either twin. So either twin can have hydrops or ascites present. Stage 5 is also either twin, but unfortunately, this is the sad ending of demise. So again, these are the 5 stages of the Quintero twin-twin transfusion syndrome. And again, we're responding to stage 3, which we know as Dopplers go bad. So that matches up with answer A, which is absent or reverse end diastolic flow. Number 5, a subgaleal hematoma as a result of operative delivery is located between which layers of the fetal skull? This is going to be answer A, the periosteum and aponeurosis. Let's go ahead and go to the next slide so we can take a look at these structures and make sure we understand them. If you follow along with me, we're going to start on the left side on the bottom. We're going to start with the dura. That's that green line over covering the red brain. So that's going to be the dura. Next up is that dotted purple line, and that's going to be the periosteum, the covering over the bone. That next arrow up, which is pointing at the green line, that's going to be the skin. So let's talk pathologies now real quick. Next up from there is going to be our caput. And of course, you know this has succedaneum after it, but we'll put caput because that's all we all know it usually. And then as we go across from there, let's make sure that we know this is a cephalohematoma. The next one is going to be a subgaleal. And the next one down is an epidural hematoma. Now this blue line over here is the epicranial aponeurosis. And that's followed by the skull, which is that dark blue structure inside the periosteum. Now let's talk a little bit about these pathologies. Caput, as you know and I know, is fluid or blood really just being trapped underneath the skin. It can cross the midline because, as you can see, it's not maintained or contained by the periosteum. So therefore, it can cross over those bony midlines and it can be anywhere underneath the skin. The next one we would talk about is the cephalohematoma. This is an external expression of a buildup underneath the periosteum against the skull bone. I would compare this right away to epidural hematoma. And I would kind of put a little bit of a line or an arrow or a flip between those two, because as you notice, epidural hematoma is literally the flip of a cephalohematoma. It's confined within the periosteum to the skull bone. However, this time it's pointing inward towards the brain instead of outward towards the skin. Subgaleal hematoma, as you can see, is not confined by the periosteum, and it's also within the epicranial aponeurosis, which gives it access to the inside of the skull as it can go between the skull bone plates. So therefore, subgaleal hematoma can be very risky and very dangerous because it's not contained by any structure that's going to hold it back. Number 6, which of the following thrombophilia cannot be tested accurately during pregnancy? This is answer B, protein S disease. Yes, I know there's tables and there's calculators that can do protein S disease for you. But again, you're using something to find the answer because it's not straightforward during the pregnancy. So the hardest or most difficult, or the one that cannot be tested accurately, is protein S disease. Let's talk a little bit about these. Antithrombin 3 deficiency is definitely the most thrombogenic and dangerous of them all. Now, protein S and C disease, I like to put them together and think of them as so cute, because they're really the least risk out of any of these, and it's the less severe disease. Now remember, protein S, just on its own, is unpredictable in pregnancy. Factor V Leiden by far is the most common that you're going to see. And then prothrombin G2021OA has the finding of hetero being decreased risk or double hetero being increased risk. If you don't remember the difference between double hetero, or complexities, and compound, then you need to take a look at those and make sure you remember them again. The key difference between compound heterozygotes and double heterozygotes, which we mentioned here, compound heterozygotes is an individual who has 2 different mutated alleles at a particular gene locus, while double heterozygote, shown here, is an individual who is heterozygous at 2 separate genetic loci. So this is going to be the difference between those two. I'll also help you out with this chart right here. These are all autosomal dominant. Let's make our studying easy. 7, a 35-year-old G4P4 presents to the emergency department following an episode of syncope. She has a known history of AUB. Her hemoglobin is 8.2 grams per deciliter, and her vital signs are stable. What is the best management? The answer here is C, transfusion. It's okay if you're shocked. There's a little bit of a knowledge piece that you have to have here. If the patient has any form of neurological issue related to hypoperfusion or hypooxygenation, they have to be transfused. This patient had syncope. The syncope is telling you that the patient had a hypoxygen effect on the brain, and therefore, even with her hemoglobin of 8.2 and her vital signs stable, she'll still require a transfusion. So let's know that 10 grams per deciliter with any neurohypoxic signs and or symptoms requires transfusion. Number 8, a 34-year-old has been using OCPs for 6 months and presents with heavy menses. Ultrasound shows a 1.1 centimeter endometrial echo complex and normal ovaries. What is the next best step? The answer here is D, endometrial biopsy. This is a person that's 34 years old, and they've been using the OCPs for 6 months, and they're still having heavy menstrual cycles. Their ultrasound shows that 1.1 centimeter endometrial echo complex and normal ovaries, but because you've had the persistent abnormal uterine bleeding despite medical management, the next best step for this patient here would be endometrial biopsy. Number 9, a 16-year-old has sudden right-sided pelvic pain, nausea, and vomiting. Heart rate is 105 beats per minute. Temp is 100.6 degrees Fahrenheit. Urine HCG is negative. What is the best management now suspecting an ovarian torsion? The answer here is going to be answer A, detorsion by laparoscopy. Remember, even if that ovary looks dead, gone, and never coming back again, you're going to detorse it and allow it to return to blood flow spontaneously on its own and hope that it'll be okay. So again, unless the ovary is bleeding and cannot be controlled, or there is something that is very concerning for a cancer, you're going to leave that ovary alone. You're going to detorse it and let it return to blood flow on its own. And remember, you don't have to do a look back for this. You can just follow the patient's signs and symptoms and do ultrasounds later. And you also do not have to hang the ovary, tack it in any way, shape, or form, although that is recommended by the ASRM if the patient is undergoing treatments for infertility and it is their 10. Which of the following is the first-line management for the treatment of orgasmic disorders? This is answer A, sexual skills treatment. The sexual skills training is things such as instruction in masturbation, understanding orgasm and what they may interpret as orgasm being or not being, and also making sure the patient understands what things they should and shouldn't be doing to help them with achieving orgasm. Before going on to medications, it's always best for examination questions to think about things that are low risk. So remember, lowest morbidity and mortality, lowest cost, lowest medication usage. Those are all going to be the things that are most important or the best treatment choice for you. 11, your patient presents at 10 weeks and is noted to have 100,000 CFU, 10 to the 5 colony-forming units, and a clean touch. She is currently asymptomatic. Which of the following is the best management? The answer here is B, nitrofurantoin 100 BID for 7 days. So remember, we don't necessarily need to know the dosages of the medications, but we do need to know how they're given and for duration, which is important too. Now, this patient does have to be treated. She's at 10 weeks of pregnancy, and even though she's experiencing what's called asymptomatic bacteria, the patient does have 100,000 CFUs or 10 to the 5 colony-forming units. This is the bare minimum of considered on a clean voided specimen to be diagnostic. So remember, you could even treat for lower with symptoms, but with asymptomatic, with a clean void, you're going to go ahead and know 100,000 CFU as your limit for treatment. And don't worry, we're after 8 weeks. 10 weeks is completely fine to be giving nitrofurantoin. 12. Which of the following is the correct management of antibiotics for intraamniotic infection when a cesarean is needed? The answer here is B, ampicillin 2 grams, gentamicin 5 mg per kg, and clindamycin 900 milligrams. Let's do a quick picture on the next page to take a look at how to remember our antibiotics here. So I always like to think of GA being go ahead. So we're going to go ahead and we're going to give our GYNT and our AMP, and then go ahead and stop them once we deliver. Now, if you do add the C, which is a C-section, then you're going to add the C, which is clindamycin, and continue for one more 8 hours after. So gentamicin ampicillin are going to be given the second that you think that you have an intraamniotic infection. You're going to give them until that person births, and whether they birth by vaginal delivery or they birth by C-section, as soon as that birth occurs, you're going to stop them. So go ahead and start them, and then go ahead and stop them as soon as delivery occurs. Now, if that patient is or becomes a cesarean section, you're going to add on clindamycin. Clindamycin, however, will not stop at the time of delivery. It will continue for one more dose, usually 8 hours after the completion of the cesarean section. So again, knowing when these drugs change and when to stop them is very important. 13, a 54-year-old presents with a vaginal bulge. On exam, you find a narrow pubic arch and a grade 2 cystocele. Which of the following pessaries would be the best for this patient? This is B, the Hodge. If you don't know a lot about pessaries, let me give you a couple of key tips to help you remember. It is good to learn a little bit about these because remember, this is something that you don't usually see a lot in training. This usually is something you see in your later office years as an attending. So let's make sure we understand some basic facts. First of all, when it comes to GynOnc and Hodge, I like to think of GynOnc as the pool to the ladder into the pool. So it's got those two bars like this that go up onto the side, and then the ladder rungs that go down into the pool water. And they're usually made out of what? Metal. There is a metal wire inside of the GynOnc. There is also a metal wire inside Hodge. I like to think of Hodge as hodgepodge. So if you ever know what hodgepodge is, it's just a bunch of things being put together. So Hodge is like a ring, but it's very flexible. So like this patient who has a narrow pubic arch and we can't get a normal shaped or sized pessary into the vaginal canal, we would use a Hodge because we can press it downward, pass it past the narrow pubic arch, and then expand it as best we could. Now, Hodge is usually used for retroverted uterus correction, but it can be used for other things as well too. Now, GynOnc is shaped kind of like the ladder to the pool. I'm going to try my best 3D here for you. But it kind of has that shape to it. So that's GynOnc. Now, rings and donuts and all of these other things are space occupying, or they can be used for incontinence, such as the ring with or without the incontinence notch, or it can have support, which is a filling of the inside. Now, if it has the ring, that's the ring going around the outside, or it can be a dish which has the ring absent. So all of these different pessaries, take a quick glance at a video online, make sure you understand the basics of them, because this is something that's highly pertinent and it does keep patients from having unnecessary surgeries. So let's make sure we understand pessaries the best we can. 14. What is the most cost-effective test for the diagnosis of androgen insensitivity syndrome versus Müllerian agenesis? The answer here is B, testosterone. Remember, individuals with androgen insensitivity syndrome are XY. Therefore, they are producing normal male testosterone levels. They're just not responding to them because they're insensitive to androgens. So therefore, if they have a normal male testosterone level, it will be androgen insensitivity syndrome, where Müllerian agenesis would not have those levels up to and including a normal male level. Let's take a look at this because I know that primary amenorrhea makes some people nervous. And even if it doesn't, it's always great to review. This is found on OB-GYN Illustrated, page 79. First and foremost, make sure you're ruling out some obvious things like pregnancy or a transvaginal septum or an imperforate hymen. Look for clues in the question or lab results that may give you some of these things pointed. After your history and physical, your next question is whether a uterus is present or not. If the uterus is not present, we're going to head with this way down the algorithm. And actually, karyotype would definitely diagnose either 46XX, which is Müllerian agenesis, or 46XY, which is androgen insensitivity syndrome. But let's also remember, we can do testosterone. And the testosterone would be a normal male level. So not elevated over that normal male level, just at a normal male level, where a patient that's 46XX molar agenesis will not have that level. Let's head the other way on the algorithm, and let's say there is a uterus present. That's going to take us to FSH, LH, and the fun game everybody loves playing of hypo-hypo or hyper-hypo. What I usually like to think with hypo-hypo is it's the non-genetic-y ones. So that's going to be more like anorexia, obesity, brain injuries, constitutional delays, things like that, hyperprolactinemia. Now on the high side, the hyper-hypo, that's going to be the things that are genetic, like 46XY swires, which remember we called the SR wires because that SRY region is what the problem is. 46XX, which is primary ovarian insufficiency, or 45X null, which is Turner's syndrome. So those can be found by DNA, and those are the things that are hyper-hypo. So again, this isn't something that you should make complicated for yourself. You should be able to answer these questions and find your way through them with simple diagnostic breakdown like this algorithm here. 15, a patient at 12 weeks presents for her dating ultrasound. You identify a twin gestation at 11 and a half weeks and identify a lambda sign. This is indicative of C, diamniotic dichorionic twinning. The lambda sign is also known as the twin peak sign. So if you're looking at an ultrasound and you have a kid here and a kid here, don't worry, they're happy. They're just upside down. The pushing of the two chorionic plates from the placentas cause the lambda or the twin peak sign to occur. Now everybody draws it upside down, but the T sign would be your kid here, and we'll put a kid right upside up for you on the other side of the amnion. This is going to be a monochorionic because there's one chorion plate underneath them, and then the amnion separates them as well too. There's other things that on ultrasound could of course help you diagnose these pregnancies, but remember all this is usually telling you is about the chorionic status of the multiples pregnancy. 16, you're going to prescribe glyburide. Which allergy should you check for as a contraindication? This is answer C, a sulfa. Sulfa allergy is necessary to look for because glyburide is a sulfonylurea. It does bind to pancreatic beta cell, adenosine triphosphate potassium channels or ATP channel receptors, and it does increase insulin secretion and insulin sensitivity of peripheral tissues. It's important to understand that it increases insulin secretion. For that reason, glyburide should be taken with or near a meal or with food because it can cause hypoglycemia. So two big things to know about glyburide is it is a sulfa drug, and it is also considered able to cause hypoglycemia because it directly affects insulin secretion. One of the other drugs we use much more commonly now is a biguanide, and the biguanide is metformin or glucophage. Metformin, a biguanide, affects in 3 different ways. It decreases absorption of glucose from the bowel. It increases insulin sensitivity at the cell level. And it also decreases gluconeogenesis in the liver. So biguanide has 3 functions that it works on for our diabetic conditions, where our glyburide had 2 functions, which is increasing the sensitivity of peripheral tissues, and it also increases insulin secretion. "17. Which is true regarding using GnRH antagonist treatment for endometriosis? The answer here is D. Concomitant contraception is necessary. We always use GnRH and agonists for the treatment of endometriosis. Antagonists are the newer of the drugs, where it cuts off at 2 levels the GnRH, which we still use as a GnRH agonist. So remember, GnRH agonists, like Lupron, usually have high flare effect. So they're often given with a progesterone or an add-back therapy. This can also be done with the GnRH antagonists, as we are seeing flare effect with them as well too, usually just not as severe. However, all of these medications will recommend concomitant contraception to be necessary. And the reason for that is they are not a form of contraception, and pregnancies that take place theoretically or would have problems due to these medications being taken at the same time. 18. Other than Trichomoniasis vaginalis, what two organisms are detected with DNA probe method? This is B, Gardnerella vaginalis and Candida albicans. 19. Which of the following is the best management for ovarian insufficiency in a 14-year-old? The answer here is A, graduated ethinyl estradiol dosing. Initial therapy includes ethinyl estradiol in graduated doses until pubertal changes are taking place and breast development is completing. Then progesterone can be added slowly to the therapy. If progesterone is added too early, it will cause tubular breasts, which are malformed breasts and cannot be reversed. So therefore, you don't want to start the progesterone right away. You want to start just graduated ethinyl estradiol, which can take anywhere from 16 to 18 months up to 1 year, where you start seeing those pubertal changes, and then you can slowly start progesterone, but making sure breast development is happening and moving along correctly. 20. Serous tubal and tubal intraepithelial lesions in transition are most frequently located in which part of the tube? This is answer C, the fimbriated section of the tube. Remember, we talked about this earlier with the STIC or stick lesion related to BRCA1 and 2. 21. Which of the following is most common way endometrioid adenocarcinoma of the uterus spreads? The answer here is C, direct extension. I always like to think of this sounding like the word droid. And droids are robots, so they need power. So they've got to put out their extension cord and plug in to a power source. So I just think of their direct extension to get their power, and that's going to be the endometrioid adenocarcinoma. 22. The unique feature of occurrence malpractice insurance is B, covers all incidents during a specific coverage period. Business of medicine is part of examination process for professional examinations. This is an important piece of what you sign in contracts or have already signed in contracts throughout your career where you have to talk about your malpractice insurance. Let's take a look at these to make sure we understand. When you have a policy active, which is the green box over here, that is when that policy is covering anything that may have occurred during that policy time. Now, when the policy ends, that's where things become a little different for these different types of insurance. So as you can see in the policy non-active area, that's where we start to see things that will change. Now, if a claim is made or an issue with your practice is made during the policy active period, both occurrence and claims made will cover that thing that happened. But once the policy ends, only occurrence will continue to cover that without any concerns or issues. So I always say, if it occurred, it occurred. It doesn't matter when you're making the complaint, it will always cover it. So again, occurrence will always cover that complaint, no matter if it was made after the policy is active or during the policy being active. Now, claims made means only when the complaint is made during the policy active time is it going to cover it. If it's made out here after the policy is no longer active, then it may or may not be covered, but most likely will not be covered by claims made. So I like to think they're claiming that it happened after the policy, but did it? And then you need to have what's called tail coverage. After the claims made policy is no longer active and it ends, you would have to purchase or have purchased for you a tail coverage. That tail coverage will continue to cover you with the policy that was active, your claims made, no matter when the complaint is made after the policy ends. 23. Which of the following medications has been shown to reduce vertebral fractures in patients with BRCA mutations? This is going to be answer C, raloxifene. It's important to know that there is a vertebral height loss in menopause. The average rate of bone loss is about 2%, and that begins 1 to 3 years before menopause, and it lasts for about 5 to 10 years with menopause. This results in an average loss of bone mineral density of about 10% to 12% in the spine and hip across the menopause transitional period or perimenopause. So there is quite a bit of bone mineral density lost. Now, loss of height can be a sign of vertebral fracture, so it does need to be taken seriously. After achieving their maximal height, women can lose up to 1.5 inches or 3.8 centimeters of height as part of the normal aging process. This is primarily a result of shrinkage of the intervertebral discs, though. Height loss of more than 1.5 inches or that 3.8 centimeters is the likelihood of a vertebral fracture is present. That's why measuring height in the menopausal state and beyond is actually a very important part of an annual examination. 24. For the occiput anterior position of the fetal head, appropriate applied forceps blades are placed. This is going to be answer A, equidistant from the sagittal and lambdoidal suture. It's easiest to just take a look at a picture. Correct placement of the classical forceps on that positioning would again be equidistant between these suture lines. So equidistant here and here. And again, your lambdoidals are back here, and this one is your sagittal suture. 25. Your patient presents with primary amenorrhea, no secondary sex characteristics, and a 46XY karyotype. The most likely mutation consistent with this syndrome is, this is answer B, mutation in the SRY gene. So what did we tell you about the SRY gene? That goes along with Swyer's syndrome. So remembering Swyer's syndrome goes along with the mutation in the SRY gene. 26. Your patient is postoperative day 4 from a cesarean delivery and has purulent discharge from her incision. What is the next best step in management? The answer here is C, wound exploration. 27. A 74-year-old presents with a 10-centimeter adnexal mass and postmenopausal bleeding. Their recent EMB shows EIN. Which of the following tumor markers has ability to predict malignancy versus benign ovarian disease with the highest specificity? This is answer B, human epididymal factor 4. If you were thinking a granulosa cell tumor, you are correct. That's what's going on here. However, this question is looking for your understanding of using biomarkers for prediction of malignant versus benign disease in ovarian pathologies. So that's why the answer is human epididymal 4. So CA125 and other markers such as inhibin B may be something that's elevated in this disease process. However, they do not have the specificity of showing benign versus malignancy that has been found with human epididymal 4. 28. Which of the following anomalies is associated with Kallmann syndrome X-linked mutations? This is answer B, cleft lip and palate. Let's take a look at Kallmann's. Kallmann's is found on page 80 of your OB-GYN Illustrated. As you can see from the image, this person's going to have problems with their nose, with smelling, which is the anosmia. And the main condition and problem related to that is GnRH not being produced. The neural cells that were supposed to leave the area of the cribriform plate did not migrate correctly, and therefore there is a deficit in anosmia and spelling, which causes anosmia and GnRH secretion in a pulsatile fashion. These individuals also tend to have long upper extremities, and they also require estrogen. They not only require estrogen, but they require estrogen to become pregnant. If this individual is pregnant, they're also going to require GnRH, like our little pregnancy fetus is holding here. They'll need it in a pulsatile fashion, which is usually done through an external pump to give them the pulsatile action to make sure that they can become pregnant. Knowing which of syndromes can become pregnant on their own or with egg donation or with any other form of assistance is really important. So make sure you understand those for each of your syndromes. Now, I did include some other things that are common with Kallmann syndrome, such as midline facial abnormalities, which the question was about, cleft palate, unilateral renal agenesis, cerebellar ataxia, epilepsy, and neurosensory hearing loss. '29. Patient presents at 12 weeks for prenatal care. She has cell-free DNA testing done, which has resulted as uninterpretable. What would be the next recommended management option for this patient? The option here is D, ultrasound and diagnostic testing. This test was done at an appropriate timing, and it was most likely done in an appropriate way because remember on exams, everything's perfect unless we're told otherwise. So therefore, it's returned with uninterpretable, which can also be returned as no result or no call. If these things are seen with cell-free DNA screening test results, then you have to actually go to doing higher level screening and diagnostic testing. You don't just repeat the test. So therefore, they may need genetic counseling, they may need ultrasound, they may need diagnostic testing of another form such as amniocentesis or other things. So again, don't just repeat it. You're going to go to a higher level of diagnostic testing or viewing problems with the pregnancy such as ultrasound if it was done correctly in every other way. 30. What is the treatment of choice for a patient with a confirmed diagnosis of adult onset congenital adrenal hyperplasia? This is answer C, dexamethasone. When patients have a 21-OHD classic, non-classic form of congenital adrenal hyperplasia, They have a prominent androgen excess. They usually report with irregular menses. They have infertility issues and often have hypertension or blood pressure problems. The first thing that must be taken care of is returning dexamethasone to this patient. "31. Which of the following aromatase inhibitors is most likely to cause osteoporosis resulting in fractures in patients being treated for breast cancer?" This is answer B, anastrozole. I just think anastrozole is nasty for the bones. Now, aromatase inhibitors stop the conversion of testosterones to estrogens. Letrozole and anastrozole are the worst, and exemestane, which is also listed here, is the least bad of the three. Anastrozole will not only lead to osteoporosis, but also proves to show the most fractures within that group. So you have to pick the worst of them. It's definitely anastrozole number 1, letrozole number 2, and exemestane is number 3. So worst of the 3, because of also high fracture rate, is anastrozole. 32. 24-year-old G0 is coming for preconception counseling. Screening should be offered for all conditions except. This is going to be answer B, Fragile X. It's important to know the prevalence of some of these things, and hemoglobinopathy is obviously not the importance here. Fragile X is actually a 1 in 4,000 prevalence. Now put these are prevalence numbers. Cystic fibrosis is a 1 in 2,500 prevalence, and SMA is a 1 in 10,000 prevalence. Pay attention to these numbers. We'll be seeing them again later. 33. Small for gestational age newborns are predisposed to all the following complications except. That's answer D, acid-base disorders. Small for gestational age newborns are predisposed to a lot of complications and problem. Obviously, respiratory distress syndrome, hyperthermia, and hypoglycemia, but you can also include your hyperbilirubinemia, intraventricular hemorrhages, of course, your necrotizing enterocolitis, seizures, sepsis, and neonatal death. 34. In adolescent patients with symptoms of androgen excess, which is least likely the diagnosis? The answer here is B, Sertoli Leydig cell tumors, which are extremely rare. Now, if you're forming a differential diagnosis, you would look at things that are like physiologic hyperandrogenism of puberty, idiopathic hyperandrogenism, PCOS. These are much more common causes that you're going to see with these patients who have symptoms of androgen excess. Other things that could be on your differential is non-classical congenital adrenal hyperplasia, androgen-secreting tumors, hypothyroidism, Cushing's disease, or severe hyperprolactinemia. These also could be causes, however, they're very unlikely. 35. When compared with the general population, obese women with polycystic ovarian syndrome do not have increased risk of. This is answer D, thyroid disease. Although thyroid disease is one of the things that you would rule out to make a definitive diagnosis of polycystic ovarian syndrome, they are not at more risk for it once they're diagnosed with polycystic ovarian syndrome. However, they are at risk for endometrial cancer, but this also has the caveat of usually being related to not only polycystic ovarian syndrome, but it's also related to obesity or increased BMI. Hyperlipidemia and diabetes mellitus are things these patients find themselves at increased risk of. They're not part of the syndrome. They're not part of the disease pathology. They're things that can be caused from it. 36. A patient presents with vaginal discharge and subsequently treated with doxycycline 100 milligrams BID for 7 days and ceftriaxone 1 gram IM once. Which results corresponds best with this treatment? The answer here is C, non-excluded chlamydia, positive gonorrhea, and a weight of 165 kilograms. Remember, the CDC put a cutoff limit of 150 kilograms or greater to be the difference between 500 milligrams or 1 gram of ceftriaxone treatment. So again, 150 kilograms or greater, that patient will require 1 gram of ceftriaxone. It's important for you to stay up to date on things such as the CDC, GBS, and ACOG practice bulletins and committee opinions that come out up to your exam. These are things that are standard of practice. So the second they're out, they are considered evidence-based standard of practice. Now, studies or just things that are found out to possibly be true, those are things that are not standard of practice or evidence-based care. So you don't have to worry about those as much. However, if it is something that's published by CDC as a standard of practice or ACOG as a standard of practice, that is something that you have to pay attention to. So make sure you have things like the CDC STI app and the GBS app by the CDC as well too. 37, a 26-year-old patient is treated for uncomplicated pharyngeal gonorrhea. What is the appropriate follow-up for this patient? This is answer B, retesting in 7 to 14 days. Any form or any case of pharyngeal gonorrhea requires retesting in 7 to 14 days, whether it's complicated or uncomplicated. 38, a G2P1 presents at 34 weeks and 3 days with history of preterm labor with new onset of painful contractions and low pressure that started 2 hours ago. She has a moderate amount of vaginal bleeding. What is your next step? This answer is going to be P. Please do an ultrasound first. This patient has no other given history. The next best step is to evaluate for a reason for that early onset vaginal bleeding and labor, and that would be looking with an ultrasound before doing any of these other things. 39, postpartum patient is being evaluated for fecal incontinence with history of an obstetric laceration. Identify the transverse perineal muscle in the following endoanal scan. The answer here is B. So B is going to be the transverse perineal muscle on this scan. Let's take a look at this and make sure that we understand how these work. The image on the left is where we'll start, and we're going to go clockwise from the lower left. This is going to be the external anal sphincter that you're seeing here. And then moving up, that dot in the middle or circle is the perineal body. The moon shape at the top is bulbospongiosis. The next arrow over to the right is going to be identifying your transverse perineal muscle, which the question was about. And then following down that right side of the picture, that is going to be your longitudinal layer, which is a layer that's found between the external and internal sphincters. And that's the internal anal sphincter, and to make it clear, it's pointing at this dark black area here. Now the image on the right is an actual endoanal scan. So let's take a look at that and see if we can copy over all of the actual findings on this scan. So we're going to go again, clockwise or left on the right image. And that's going to be our internal anal sphincter, our external anal sphincter, our transverse perineal muscle, and the longitudinal layer. So your internal anal sphincter is here. Your internal anal sphincter is pointing to here. Your longitudinal layer is the line in between those two. And this little structure right here is your transverse perineal muscle. 40. You have completed a B-Lynch compression suture technique for a postpartum hemorrhage patient. Which of the following is the least likely complication? The answer here is D, bowel entrapment within compression sutures. This is the least likely complication of this particular procedure. However, requiring a hysterectomy still is on the board. Continued hemorrhage will of course be there, and uterine necrosis. If the uterus is folded over in a right angle manner versus rolled down, those uterine vessels on the side of the organ will be pinched and the blood flow to the fundus will be cut off. Therefore, uterine necrosis is much more likely to happen than bowel entrapment, as the sutures will release, break down, or be along with the uterus as it goes down and it's compressed. 41. Which of the following is the most common ultrasound finding suggestive of congenital CMV? The answer here is C, periventricular calcifications. The most common ultrasound findings suggestive of congenital CMV are echogenic bowel and symmetric in utero growth restriction. And also these findings go along with periventricular calcifications. So if we see those calcifications, they're going to be just along the ventricles, periventricle, and it just makes these almost like nice little C shapes for CMV inside the head. So we're going to remember periventricle goes along with CMV. 42. Hypovolemic shock is best characterized by, the answer here is D, decreased pulmonary capillary wedge pressure, increased systemic vascular resistance, and decreased cardiac output. As surgeons and as obstetricians, we deal with a lot of things that have to do with shock and bleeding. We should probably be familiar with these. So let's take a look at an image that comes out of the OB-GYN Illustrated Guide, page 54. As you can see in septic shock, systemic vascular resistance is down. Think about third spacing in septic shock, and there's nothing left to resist because the vessels are just leaking out the fluid. They're usually exposed to toxins, and those toxins from those bacteria are causing them to just leak out that fluid. They can't hold the fluid within them. Therefore, systemic vascular resistance is down and unable to help that patient in septic shock. The next one down is cardiac. Cardiac shock is cardiac. It'll have the most significant cardiac output effect showing in its numbers. Hypovolemic, two things go down. That's going to be your pulmonary capillary wedge pressure because there's nothing coming back. And then also your cardiac output's going down because there's nothing to put out. Therefore, increased pressure on systemic vascular resistance. 43. Of the following, tension headache is most characterized by, this is answer D, frontal and occipital location. Remember, those tension headaches, that's your end of your night call or your really long shift. You're trying to just do your notes. You're trying to just get things done. Somebody's asking you about doing an M&M conference next week, which is not nice. And you have that headache that just climbs up the back of your neck from your shoulders right into the back of your head. And it forms this horrible tension headache that's a band-like tightness that encircles your entire scalp. All you need is to rest, sleep, and get away from the hospital, and it'll be better. That's a tension headache. Different from things like migraine headaches, which last an extraordinarily long time, which would be answer A, nausea and aura, which also go around with migraine headaches as well too. 44, in a 25-year-old, which of the following is the likely fecundability rate in 1 year? The answer here is D, 90%. Let's make sure we understand fecundability and fecundity. Fecundability is the ability to get pregnant. So the ability to get pregnant on a monthly time frame. Fecundity, let's take a look at that. Fecundity is the ability to get pregnant, carry the pregnancy, so remain pregnant, deliver live, and take that kid home. All of these things are components of being able to call fecundity. So fecundability, ability to get pregnant every month, and fecundity, pregnant, carry pregnancy, deliver a live pregnancy, and take that kid home is fecundity. So that's an important thing to understand about those. But let's take a look at the fecundability and its numbers. So under fecundability, at 30 days or 1 month, we're looking at about 20%, a 20% chance of being able to become pregnant. At 3 months, we're looking at about 50% chance that they should have become pregnant. 6 months, we're looking at 75%. And after 1 year, that individual has a 90% chance that they should have been pregnant if they're having regular unprotected sexual activity or doing those things that are going to contribute to a successful pregnancy attempt. 45. A patient with von Willebrand's disease is more likely to hemorrhage in which of the following pregnancy scenarios? The answer here is D, the postpartum period. As we know, these individuals will have that DDAVP put up onto the wall to make sure it's available for their after-birthing experience to make sure they don't hemorrhage and bleed and not have it controlled. So it's that postpartum that's actually the scariest and worst part, because during the pregnancy, the physiologic changes of pregnancy actually decrease the chance of hemorrhaging and bleeding. Let's take a look at von Willebrand's disease. Von Willebrand's disease is very unique in a lot of ways. However, there's 3 main types that we pay attention to: type 1, type 2, and type 3. Now, I like to tell a little bit of a story to remember which one is which in the von Willebrand's disease. Let's say there's a factory, and that factory is making, I don't know, widgets. And when they're making widgets, they're doing pretty well, but the company gets into a little bit of trouble. So they don't want to do anything about their quality because they want their quality to stay as good as it's always been to try to save the company. So they're going to make a high quality product still, but they don't have the money to make as much as they possibly could at one time. So their quantity is going to go down. So von Willebrand's 1 is a quantitative effect. Now, after a while, they try to make really good quality products. They just can't make as many of them. So people stop losing interest because they're not seeing them out there in the market. and they unfortunately lose more money and they have to drop their quality. So type 2 of von Willebrand's is a qualitative problem. Eventually, unfortunately, because the quality goes down, there's not much of the product anymore, the company will go out of business, and that's going to be the absence. And the absence is type 3 of the von Willebrand's, which is the worst of the three if you had to have one. Now, when we're talking about these, there's also an interesting thing about their inheritance pattern. Type 1 is approximately 3/4 of the cases of von Willebrand's, and it is inherited autosomal dominantly. Type 2 is unique. It's one of the very few things out there that actually has two inheritance patterns. Most commonly, it's autosomal dominant, but rarely it does have a form of autosomal recessive because there are subtypes of type 2 von Willebrand's disease. Type 3 is absence, and it's inherited autosomal recessive. Thank goodness. And that's less than 5% of cases overall, which is pretty rare. Now, the clinical outcomes of type 1 can be bleeding anywhere from 0 to severe. Type 2 can be bleeding, but it's always moderate to severe. And type 3 is bleeding very severe. Now, we're surgeons, so we also want to know what we need for surgery. So let's make sure we understand that we just need DDAVP to be present for type 1 and type 2. However, von Willebrand's factor is actually needed for individuals going to surgery with type 3. 46. What is the effect of increased intrauterine pressure during diagnostic hysteroscopic procedures? This is answer C, increased intravasation. So again, if you have those increased intrauterine pressures during those diagnostic hysteroscopic procedures, and if they exceed the MAP of the patient or mean arterial pressure, which is usually 80, but can be between 80 and 100, then they will have increased intravasation of the fluid. Now, depending on the fluid media you're using, that may cause problems and concerning issues for the patient and some treatment complications. So let's go ahead and talk about that later. But right now, I want you to understand that if your pressure gets to 100 or more mmHg during a procedure such as this, it increases the risk of the patient having intravasation and having either pulmonary edema or having hyposalt problems of some of the other fluids. 47. A patient presents with a vulvar lesion that is flat dome-shaped and umbilicated. The best provider-applied treatment would be the following. The answer here is C, podophyllin resin. There's literally a difference between which things the patient can apply and which things the provider apply when it comes to treatment of molluscum contagiosum. Hopefully you recognize this DNA pox virus by its very, very significant findings of a flat dome-shaped and umbilicated lesion. Many times patient wants these cut off of their body, and shaving them or cutting them off or excising them, usually ugly scarring and problems, and I try to tell them this is not the best way to do it. However, treatments applied to them usually work pretty well, and of course, don't leave that scarring and problems that other things do. Let's talk through the provider-applied or completed therapies, and remember those, and the other things would, of course, be patient-applied. Number 1 can be cryotherapy. Number 2 can be the podophyllin resin that the answer of the question was. This is 10 to 25% usually. Number 3 is trichloroacetic acid or BCA. Those are very potent at 80 to 90%. And the 4th one would be surgical removal in some way, shape, or form, either shaving or cutting. So these are things that must be done by doctor. Other things would be patient. One of the ones a lot of people get confused is podophylax or podophylax, which is 0.5%, but it's a very diluted down form of podophyllin resin. So podophyllin resin is a highly concentrated form, which must be done by the doctor, but podophylax can be done by the patient. '48. Which is the greatest risk for placenta accreta? The answer is A, history of cesarean with current placenta previa. Women at the greatest risk of placenta accreta are those who have myometrial damage caused by a previous cesarean delivery and have an anterior or posterior placenta previa overlying the uterine scar. So this patient has a history of cesarean with a current placenta previa, which puts them at extremely high risk. These other things have risk, of course, correlated with them, but not as high of a risk as answer A. Also remember that the presence of placenta previa also increases the risk at the times that it's been present. So in the placenta previa presence, there is an increase in risk of placenta accreta, and that's going to be 3, 11, 40, 61, and 67%. And that's going to be, of course, at the first time that this occurs, the second, third, and so on. So those are your repeat cesarean deliveries. So first repeat, second repeat, and so on. 49. A G1P0 presents to the ED for vaginal bleeding at 9 weeks. Ultrasound shows a subchorionic hemorrhage. What is the worst outcome for this pregnancy? The answer is D, early pregnancy loss. This patient's only at 9 weeks. Early pregnancy loss would be the worst outcome for this patient because it would be soon and they would lose the pregnancy that's currently occurring. Other things, of course, are horrible outcomes or bad outcomes and would be concerning, but this patient needs to make it past early pregnancy loss before those things can be a problem. And early pregnancy loss is obviously something that can occur here. Question 50. Which of the following is the leading cause of septic shock in pregnancy? The answer here is C, pyelonephritis. Remember that acute pyelonephritis complicates 1 to 2% of pregnancies, and it occurs most frequently in the second and third trimesters, as the physiologic changes of pregnancy make it more likely to occur. Pyelonephritis will develop in about 40% of untreated or subtreated lower UTIs in pregnancy. And up to 20% of those, so of the 40%, 20% of those will get pyelonephritis. And can develop sepsis. So treating your asymptomatic bacteriuria that comes positive back on your tests, or treating a patient with a known UTI is very important in pregnancy, and making sure they take the treatment all the way till the end. That way, preventing that 40% of untreated or subtreated from becoming lower UTIs, where 20% of those can become pyelonephritis and possibly develop urosepsis, which is very dangerous and deadly in pregnancy because it can end up with an ARDS situation in sepsis. Thank you for taking exam number 2. It's one of my favorites.